Okay, thank you. Well, welcome everyone. Good afternoon. Still good morning to those of you on the West Coast. I'm Linda Carpenter, and I want to welcome you to this next webinar, the series that we've been doing every month for the last 10 months. And this one is the impact of maternal opioid use in pregnancy, infant withdrawal, and developmental outcomes. And in just a minute, I'm going to introduce you to Dr. Sharon Burke. I wanted to take a couple of minutes to go back and remind everyone that the purpose of this particular webinar was to really look at identifying and responding to infants who are prenatally exposed during pregnancy, and with the greatest concern being exposure to opioid use at this time. We had sent you some information. We know that the protocols that hospitals use vary, drastically within states, across states, and we've had a lot of requests for protocols, clinical pathways for how to identify and manage infants who are prenatally exposed. And so in preparation for this webinar, we sent you an example of one from Children's Hospital in Philadelphia. We're also going to ask Dr. Burke in her presentation, she's going to walk through their clinical pathway. These are both examples. They're not intended for us to say this is the exact way that you need to do this, but it certainly is to give you some good examples of what other hospitals have done. We're going to focus this webinar, like I said, on the identification and treatment of neonatal abstinence in infants in a hospital setting. In prior webinars, we've in pregnancy, the best way to do that, engagement of obstetricians, and we've talked about the importance of medication-assisted treatment and appropriate treatment for women who were using during pregnancy. We received over 120 questions in preparation for this webinar, and many of them were very similar. We've sort of gone through and organized them. We're not going to have an open mic. You do have a chat log. You see on the right-hand side of your screen there's a chat log, and so if during Dr. Burke's presentation you hear something that you want to know something more about, please feel free to enter that there. I'm not going to promise you that we'll get to your question during the course of the webinar, but we certainly will work with her afterwards to respond to questions that come up. Many of the questions that were sent during the registration process had to do more with mother's use, appropriate treatment, why medication-assisted treatment, and a number of things that were covered in previous webinars. And so I realize that there are a lot of you new to this that are joining and may not have had the benefit of those webinars previously and might not have had that information. So we'll work to make certain that we get that out to you. We'll look at the questions that come in and talk about how to respond to them, whether that's sending you prior information, research that we have, or prior webinars, so that you have answers to those questions as well. So let me take this time to, I want to say one more thing about the questions. There were also several questions that came in, and I'm fairly certain these came from our Minnesota folks, and so thank you for doing that. Questions that were specific to work in the tribal communities, and we will talk afterwards about how and where and with whom to best address those questions, because I think they're very, very critical for your work, and so we want to be responsive to that as well. So let me take this opportunity to introduce you to Dr. Sharon Burke. We met Dr. Burke when we were on our site visit in New Jersey. We were very pleased with the presentation that she did at that time and very interested in the work that Children's Specialized Hospital is doing around this issue. So we asked her to put together a presentation for today, and I have to tell you that she's spent an immense amount of time really thinking through the questions that you've asked and trying to incorporate that into her presentation and provide you with enough information about what the work that they're doing at their hospital and some of the research they're doing. So Dr. Burke is the clinical director of the Infant Toddler Rehabilitation Program at Children's Specialized Hospital in New Brunswick. She joined in 1993. She's also a clinical instructor in pediatrics and neonatology at Rutgers University and Robert Wood Johnson. She did a pediatric internship and residency at Newark Beth Israel Medical Center. And from 1989 to 1993, Dr. Burke was the clinical director of the NICU at University Hospital, Newark, New Jersey. She graduated from Ross University School of Medicine in 1983, and she's won several awards and honors for her work. Dr. Burke, I want to thank you for all the time that you've put into this and your gracious offer to present today. And I'm going to turn it over to you.
Thank you, Linda, and to CFF for graciously inviting me to host this webinar. I find it very exciting. I'd like to say a big welcome to all my colleagues and participants today. Welcome to my home state of New Jersey. This is a topic that is near and dear to my heart and to many of you. And what I hope to do today will be to present an overview of the mother-child dyad and the complexity of this problem. I have tried to update the presentation with as much research and evidence-based protocols as I could find, and those that are as current as possible. I tried not to go back beyond 2012 and actually just updated it with information from 2014 and 15. I'm just trying to advance the slide. Okay. The objectives for today would be to hopefully be able to define and distinguish the difference between neonatal abstinence syndrome and infant withdrawal, understand the changing demographics of maternal substance use, describe benefits of an inpatient program, including detoxification and rehabilitation, to discuss infant developmental outcome measures and future areas of research. Certainly when we talk about the mother-child interaction during pregnancy, it is a complicated one, and there are many, many factors that we take into consideration when talking about the health and well-being of both mother and fetus. In things such as infection, diabetes, IVF, pregnancy-induced hypertension, maternal age, uterine and placental indicators, alcohol, cigarettes, marijuana, illicit drugs, and prescription medications. There is probably not one of those items that impacts the mother that it does not in some way also impact the developing fetus. And we want to talk about that in a little more detail in a few minutes. There are three very big overriding thoughts that we should consider when talking about public health issues that pertain to the mother and the child. First of all, setting the stage, there's been an increase of over 300% in overall sales of prescription painkillers in the United States, of which there was a 33% increase in the use of prescription analgesics in pregnant women. I suspect that this number is somewhat underrepresented. Opioid exposure in high-risk pregnancies does call for guidelines among national agencies that protect both the pregnant mother, the fetus, and subsequent newborn with NAS. This was a policy statement by the National Center for Substance Abuse and Child Welfare. There was further discussion that medication-assisted treatment with methadone or buprenorphine is safe and necessary to prevent maternal relapse during her pregnancy and infant demise or severe IUGR, intrauterine growth restriction. This policy statement came from the committee's opinions of the American Academy of OBGYN, the American Society for Addiction Medicine, and the American Academy of Pediatrics. So these are several very large, well-reputed organizations that absolutely recommend treatment of moms who are going through their own struggle with opioid or drug polysubstance use to be treated with medication-assisted treatment during pregnancy. To not treat a mother during pregnancy would be to cause not only fetal demise or severe prematurity, but also consequences to the mother that would make it an unsafe pregnancy. And then lastly, there are overarching principles developed for the identification and treatment of pregnant women with substance use and their newborns, as well as protection against the discrimination, stigmatization, and criminalization of this use. And that was by the World Health Organization in 2014. So it is really my firm belief that we treat these moms with respect, with dignity, and integrity, and that we provide them the very best care that medicine has to offer And in doing so, we will also then protect the fetus. In terms of identification of maternal substance use, we know from, again, the Committee of American College of Obstetrics and Gynecology that screening tools are entertained for the purpose of identifying at-risk pregnancies. And here I really have to say that that relationship between the obstetrician and the pregnant mom really should be built on trust and respect. And this is the part of medicine that is an art, not just a science. It takes a well-experienced obstetrician to engage a young mother who may feel embarrassed, who may feel ashamed in admitting that she is taking or is using either illicit drugs or abusing drugs of prescription. And it really is up to that experienced clinician to engage her, to make her feel comfortable to discuss that not only is important that you be honest, but that we can continue to test you during the pregnancy, do routine screenings so that we can keep an eye on your pregnancy and on the developing fetus. Once that level of trust and respect has been established, it will be so much easier for the mother and obstetrician to go forward and have a healthy pregnancy. The obstetrician and colleagues should be doing routine urine toxicology screens, and they should also be referring these mothers to treatment centers with an addiction specialist, as well as many have recommended that it be the obstetrician who makes that very first appointment for the mother while in his or her office. Along with this increased rise in maternal drug use, we have, of course, seen an epidemic rise in neonatal drug withdrawal. One of the most recent studies by Patrick et al. In 2012 points to a rate of NAS of 4.4 per 1,000 live births. The ICD-9 code for this is 779.5, and my colleague Dave Babitsky has just given me a paper to tell me that the new ICD-10 code will now be P as in Peter 96.1. And again, when we go forward talking about insurance and establishing understanding within companies, this will be an important ICD code to remember. 71% of moms report use of prescription pain medication through the pregnancy. 15.5% report illicit drug use. 10% of pregnant women report the use of prescription psychoactive medications. 8% of teenagers, the ages of 14 to 17, report the use of prescription medications such as pain meds, antidepressants, anti-anxiety, and stimulants. Hospital care expenditures are quite high. Again, in recent articles by Patrick in 2012 and again in 2014, and the Healthcare Research and Quality Commission in 2015 report national aggregates in 2012 up to $595 million. Increased maternal hospital stays related to substance use have increased by 7.9 to 1,000. Neonatal hospital stays related to withdrawal have increased by 71%. The infant mean length of treatment of methadone is 17.4 days versus 22.2 days for morphine. The mean infant length of stay for methadone is 21 days versus 25 for morphine. 20% of these neonate stays are also related to low birth weights and difficulty with gaining weight, failure to thrive, and 79.9% of the cost is covered by Medicaid. So we should talk a minute about the definition of neonatal abstinence syndrome. It is a constellation of signs and symptoms that occur in newborns involving the central, autonomic, and gastrointestinal systems after abrupt cessation of in utero exposure to substances, especially opioids. 55 to 94% of exposed infants will develop signs of withdrawal. Not all infants will require treatment with pharmacotherapy, but all infants should receive non-pharmacologic interventions. The pathophysiology of opioid withdrawal has to do with its effects on receptors in the CNS, the GI system, and the autonomic system. We are talking about opioids that are occurring naturally in nature, derived from the poppy seed, synthetic agonists like heroin, methadone, fentanyl, OxyContin, partial agonists like buprenorphine, and endogenous opioids such as endorphins. These activate the mu receptors in the noradrenergic nucleus of the pons in the CNS, and it produces a state of analgesia and euphoria. There are also significant alterations in GI motility, and autonomic hypersecretory phases can be seen in the newborns. These opioids act to block the action of glutamate and inhibit the release of norepinephrine. With abrupt discontinuation of maternal opioids at birth, we see a supernormal release of norepinephrine with autonomic GI and behavioral disturbances such as sleep deprivation, significant self-stim patterns, alterations with feeding, and hypermetabolic states, as much as you are seeing in your full-term infants. And the hypothesis for this is that there are decreased receptor developments and decreased receptor sensitivities in the preterm infant. There's decreased cumulative exposure in the preterm infant, decreased transmission across the placenta during early gestation, and decreased fatty tissue stores. And we know that opioids are lipophilic molecules. In terms of pharmacokinetics, withdrawal is a function of the half-life of the opioid. And we take into account the newborn's liver metabolism and renal clearance. And we do know that half-life in the newborn tends to be a little bit longer than in adults. Morphine withdrawal may present 24 hours after birth, but typically between 24 to 48 hours. Methadone, 24 to 72 hours after birth. Buprenorphine may present between 40 to 72 hours after birth. Jansen, in her article, discussed the fact that there is a less severe NAS and withdrawal following maternal buprenorphine dosing throughout pregnancy. Benzodiazepines and barbiturates may delay the presentation of withdrawal and may also exacerbate the symptomatology and Finnegan scores. Polydrug substance abuse and alcohol exposure may also lead to a more severe and prolonged withdrawal phase. Symptoms of withdrawal, therefore, may be delayed until 7 days after birth. And a recent study in 2014 talks about a biphasic pattern of withdrawal, where the initial phase may last from 1 to 2 weeks, followed by a relapsing course for several weeks thereafter. In terms of pharmacokinetics of stimulants, cocaine and amphetamines, there is not so much a withdrawal or a toxicity syndrome, but rather an effect. These medications actually have a very short half-life, and symptoms can appear before the half-life. They stimulate the release and block the reuptake of neurotransmitters. They rapidly cross the placenta. Infants often present with hyperactivity, excessive jitteriness, exaggerated moros, and exaggerated sucking patterns. It is not yet resolved if cocaine limits brain development or head growth. In terms of prescription medications, we see a lot of mothers coming in who are on SSRIs during the pregnancy. Many of those used during the third trimester may be linked to neonatal signs of excessive crying and jitteriness, sleep disturbances, feeding disturbances, hypoglycemia, and seizures. They liken the serotonin syndrome in adults to what we might see in infants, where in an adult we see changes in mental status, autonomic hyperactivity, and neuromuscular abnormalities. We are seeing alterations in the infant of disturbed responses to an environment, jitteriness, sleep patterns that are also altered. SSRIs may prolong the severity of an infant who is exposed to opioids in utero. Again, recent reviews are inconclusive as to adverse neurodevelopmental outcomes in newborns born to women treated with SSRIs. The toxicology that is most commonly performed is urine toxicology in the infant, which may provide information a few days up to delivery and 72 hours after birth. Meconium analysis can be used to detect maternal opioids and cocaine exposure after the first trimester and up to 72 hours after birth. Hair analysis can indicate maternal use in the last trimester and up to 3 months postnatal life. And umbilical cord tissue is fast becoming an easy and rapid collection to foster its use as well. In order to assess what is happening with the newborn, a scale was created by Finnegan in 1986, and he noticed significant patterns of behavior and abnormalities that affected the CNS, GI systems, and the autonomic system. Many times a DIPUS worker will come up to me and be a little confused because mom reports significant history of opioid use, or she is in a methadone treatment program, and yet the baby's urines were negative. That is not unusual to hear. It is not a perfect science. Sometimes the specimens get lost, they get contaminated, and we don't always have positive urine toxicology. That is why clinicians trained in Finnegan in assessment of the newborn and Finnegan scale assessment are very important, because we would still want to treat an infant even with a negative urine toxicology. If there is a strong maternal history, those infants should be scored and treated appropriately, both with pharmacologic and non-pharmacologic interventions. Some of the signs we see in the CNS would include seizures, tremors, high-pitched crying, high tone, hyperreflexia, yawning, and sneezing. Vasomotor problems could include sweating, nasal stuffiness or rhinorrhea, mottling, hypertension. GI systems include issues with feeding, intolerance, vomiting, or diarrhea, poor weight gain because of a hypermetabolic state. A score of 1 is given for the least adverse effect in these categories, and a score of 3 for the most adverse effect in these 3 categories. It is recommended by Hudak and his beautiful article in Pediatrics in 2012, strongly recommended and endorsed by the American Academy of Pediatrics, that Finnegan scoring should start within 2 hours after birth for those infants that we are concerned with, and then thereafter every 4 hours. If this score is greater than 8 for 2 or more consecutive scores, one should consider pharmacotherapy. One should consider weaning medication every 24 to 48 hours for 2 consecutive scores less than 8, and this dose may be decreased by 10 to 20%. He recommends that medication be discontinued when morphine dose is less than 0.04 milligram per kg per day, or methadone less than 0.05 milligram per kg per day. I did have time to look at the protocol that was distributed by CHOP, Children's Hospital of Philadelphia, and I will tell you that the only difference I saw was that they recommend medication be discontinued when the morphine dose is less than 0.02 milligram per kg per day. This is a copy of the Finnegan, modified Finnegan scale. We train all of our nurses on the scales. They have to go through yearly competencies, and we try to encourage objective scoring. The infants should all be scored after they've had a feeding, and our nurses actually do a very good job with this. In terms of pharmacotherapy, according to the American Academy policy statement, there is no optimum absolute treatment, although treatment with the same class of drug used by the mother is preferred. Recommendations would be one could use morphine, short-acting medication starting at 0.04 milligram per kg per dose. every 3 to 4 hours. A longer-acting opioid, such as methadone, 0.05 to 0.1 milligram per kg per dose every 6 hours. There are some protocols out there that talk about dosing it every 12 hours. Phenobarbital should be considered as an adjunct to therapy, not as a primary treatment. One would load with 15 to 20 milligram per kg, and then a maintenance dose of 3 to 4 milligram per kg per day while monitoring levels. Benzodiazepines are also considered adjunct therapy for all polysubstance use, and for moms who have had significant alcohol. It is not. Neither phenobarb nor benzodiazepines should be considered the first line of treatment for opioid use. Paregoric and tincture of opium are no longer recommended due to neurotoxic agents. There are studies out there looking at clonidine and buprenorphine treatment for newborns requiring this. They're incomplete in terms of numbers, and it is suggested by the AAP that more studies continue to look at the use of clonidine and buprenorphine. Buprenorphine is a sublingual medication. Clonidine, they've had some problems with dosing in small doses and some problems with hypotension. Naloxone should not be used as it precipitates seizures. Supportive intervention and services should always be considered for these babies, and that really is our first line of defense. We should consider the impact of the environment on these infants and should modify lighting. Calming strategies should be used, such as gentle rocking, swaddling, and therapeutic bath. Sensory stimulation can include infant massage, soft music, low lighting. Always we want to train parent and caregivers how to handle these infants. Calming strategies. Therapies, which we employ here to help these infants who tolerate handling and positioning. Many of them have such high tone that they cannot even achieve appropriate developmental postures. Their sensory responses are maladaptive, and many of them have difficulty with feeding. We also want to maximize nutritional support due to their hypermetabolic state. One should consider high calorie density formulas, fortified breast milk, and also to consider other GI symptomatology that may need treatment, such as reflux and dysmotility issues. We work very closely with the Division of Child Protection and Permanency, protective agencies. We work with the WIC offices, early intervention referrals, outpatient referrals, and visiting nurse referrals are all made prior to discharge. We also work with obtaining prescriptions if any child needs to go home on medications for reflux, for constipation, and car seat checks. The long-term outcomes are, in terms of mortality, are very, very low. There is a report that talks about a possible increased risk of SIDS in methadone-exposed infants and an increased risk in cocaine-exposed infants. That was one article in 2005, and I have not seen more current literature on this. The incidence of myoclonic seizures is anywhere from 2 to 11%. And in an article published by our research from last year, we showed some significant delays in the areas of cognitive and receptive language. So I wanted to share with the audience a little bit about our program here at Children's Specialized Hospital. It's a little different in that we are not an acute care hospital. We're an acute pediatric rehab hospital. The Children's Specialized Hospital, we are the largest pediatric acute rehab hospital in the United States. We're a 68-bed inpatient hospital. 34 of those beds are dedicated to infants. We have over 23,000 outpatient visits a year. Our medical teams include infants and toddler, brain injury, spinal cord, chronic illness, pain management, and orthopedic. We have more than 200 admissions to the infant team alone every year. To date, this year, we have 17 babies in-house being treated for NAS. We are a specialty hospital. We are a member of the Children's Hospital Association. Many of our referrals come from the tri-state area. We are recognized by Leapfrog and one of the top rehab hospitals in 2014. So our mission and vision is very clear As an infant rehabilitation program, we believe our goals are to treat infants, help them maximize their full potential, educate families, seek to establish evidence-based protocols, and establish research in clinical areas where we can add meaningfully to the literature. There's a beautiful article that came out by Jansen out of Johns Hopkins in 2007, and she talked about the basis for NAS and dysfunctional neurobehaviors in newborns. And she feels that it's due to poor fetal adaptation to changes in maternal vagal tone in response to opioids. She feels that this is the basis for the newborn physiologic and neurobehavioral dysregulation. She also mentioned that chronic opioid exposure may lead to placental insufficiency, and that treatment should be aimed at moderating both physiologic and epigenetic factors. Following with this trend of thinking, it is critical that every mother who is identified as having opioid either use or exposure be followed very closely by a center of obstetricians and addiction specialists that understand the pathophysiology of opioid exposure and take that mother successfully through a pregnancy that will protect her health and that of the fetus. So I'd like to propose that the components of a program for infant withdrawal would include non-pharmacologic interventions, staff competency and training with the administration of the Finnegan scales, a standardized protocol for the initiation of medication-administered detoxification and a weaning process, maternal caregiver teaching with home simulation testing, identify barriers to discharge, discuss the withdrawal. The withdrawal process is complex, and one must be certain that the infant is stable prior to discharge home. We should assess the infant's needs for early intervention and outpatient therapy. We should provide ongoing support for the mother and the infant upon discharge, and we should continue with both medical and subspecialty follow-up where indicated. So we are a rehab hospital, and I have a very large component of therapists that work with me with our babies who are born going through withdrawal. I have a team of about 16 therapists. In terms of physical therapy, our therapists are all masters and PhD trained, and they work with the recruitment of muscles for age-appropriate and developmental postures. Again, the neuromuscular tone on some of these babies is so high that it is very hard to get them into a position that protects their airway and protects the joints. So the therapists work very hard both with the infants and with the parent or caregiver to help them reach that range of motion and not cause injury to any joints for the infant. We actually have an aquatic therapy pool that is a very nice way to help with the spasticity. We find that with good physical therapy and ranging, we do not need to use medications such as Ativan for tone management. Our OT therapists, occupational therapists, work very hard with increasing the motor patterns for infant development. So we believe that by increasing and repetition of motor patterns, you imprint for neuronal conditioning. Many of these babies come in and they are rapid breathers, they're tachypnic, they're shallow, and it's very hard for them to eat if they're breathing so quickly. We work with a lot of conditioning through OT to work with chest wall movements and compliance, rib cage. We try to help descend the rib cage with kinesiotaping. And we work with, our speech therapists work with infants who are having problems with feeding. If you've ever worked with a baby going through withdrawal, they tend to just feed rapidly, quickly. They do not pace themselves. Many of them don't have a good closure and seal on the nipple. They leak formula, and it's no wonder they have a hard time gaining weight. So our speech therapists work quite a bit with oral motor structures, patterns, and pacing for these infants. In some cases, the infants that are having the greatest amount of difficulty, we actually use vital stim or neuromuscular electrical stimulation to help gain the appropriate suck-swallow breathing patterns for these babies. We also do a lot with motor planning in that we want the babies to be very aware of themselves in relationship to their environment. So sensory input is critical. Babies learn through their senses, and if they are stressed and they're not able to pay attention to appropriate sounds, to visual stimulation, to tactile stimulation, and if they keep fighting or pushing away from these stimulus, they will never learn. So one has to overcome some of their sensory maladaptations in order to get them to learn how to use their hands to reach for toys, hands to mouth. This is all very necessary, but you'd be surprised how many of these babies lack these very basic skills. We want to also work with cognitive processing. Babies learn. If they cry with a wet diaper, it's important we react to change the diaper to reinforce that behavior because that's appropriate for a young infant. We teach a lot of this to the mothers. Many of these are first-time moms, and they really don't have an idea of what is good parenting and especially how to handle a baby who's crying. We take them through calming strategies one step at a time so that they know different interventions, and each child is different. We customize a behavior mod program for each and every baby. So this is a one page that looks at our overall program and protocol. The large circle is on the day of admission. We review all transfer information and history, do physical assessment. We do a medication reconciliation and family orientation to the program. Our medication-assisted treatment protocol follows along the recommendations of the AAP guidelines by HUDAC. We are a specialty hospital, and we get referrals from the tri-state area. So I have some babies coming in on morphine, others coming in on methadone. We do not change the medication that the baby is admitted on. We continue with that, and we proceed with a treatment and weaning protocol for either morphine or methadone. We are starting to look at our outcomes in that regard, and preliminary results show us that there really is no difference in length of treatment, statistical difference in length of treatment or length of stay, whether we use morphine or methadone for those babies that require medication pharmacotherapy. If needed, we'll do electrolytes, CBC, glucose levels. Our nursing plan of care focuses on the Finnegan scores every 4 hours, daily weights, weekly head circumference, and monthly heights, vital signs, Q-shift, and as needed, continuous monitoring of skin integrity, carryover of the therapy protocols as administered by our therapist, family training in CPR, medication administration, not for opioids, but for medications other than that, such as reflux meds, meds for gas, and if there's any other medication required, and immunizations as needed. A nutrition consult is held daily, and we pay very high focus on the weight gain and growth curves on these infants and their growth velocity trends. Many of them come in at a severe IUGR status with growth at the 5th percentile. We work very hard that these infants tolerate the formula and that they continue to grow along a growth curve. Therapy interventions, as I mentioned, include many interventions. And our discharge criteria, all our babies must be discontinued safely off their medications that were used for pharmacotherapy for detox. Our Finnegan scores, we like to see all of them less than 8 for a minimum of 72 hours prior to discharge once the baby is off their medication. These babies should all demonstrate age-appropriate weight gain. We also do Bailey 3 developmental assessment on all our babies with NAS. This is performed by an independent psychologist who does not treat this infant. We work with DCPP and work with them to partner and identify the appropriate caregiver for time of discharge. We make referrals for visiting nurse, WIC, early intervention, outpatient therapy if needed. We do car seat safety checks. We obtain the medications for the mothers. We have a pharmacy right on campus, so any other medications the infant may need, we obtain for these mothers prior to discharge. We make sure that they have formula prior to discharge by using WIC, and we make all of the medical and subspecialty follow-up appointments at time of discharge. Some highlights of our program. Our medication-assisted treatment is performed by an experienced physician. We do a steady taper off narcotics, continuing to monitor for weight gain and growth. We manage withdrawal seizures in tone with medication if necessary. We encourage breastfeeding where appropriate. We continue to provide nutritional support for weight gain. We treat other symptoms of acute gastritis, dysmotility or reflux or constipation. We do a 3-channel 12-hour pneumogram prior to discharge to ascertain if a child requires monitoring with an apnea monitor after discharge to home. Our nurses are all competent and can administer the Finnegan assessment scale. We do very rigorous parent teaching with support and education. After the families have learned each individual aspect of care, be it therapy, be it medication administration, CPR, feeding, preparation of high-calorie formula, we then ask them to do an 8 to 12-hour independent provision of care where they provide total care in the hospital. We supervise, but we do not interrupt their care. If they fail that testing, then we go through the teaching again, and they repeat another independent provision of care exercise. We work with a local counseling center right here in New Brunswick. It is within walking distance from our hospital, and they provide MAT for the mothers who require this. Many mothers come from counties that are too far from us, so we allow sleeping in and rooming in with the babies. The mothers can walk right up the street, get their medication and their counseling, and come back and spend the time that they need with their infants. We also have a nearby WIC office that we work with who will provide the checks for WIC, regardless of what county in the state of New Jersey the mother is from. Then when she goes home, the checks then come out of the local office from where she lives. We have an on-site pharmacy that provides any medications the child might need prior to discharge. We do have a select car service for some mothers who do not have transportation or means to get here. We have bedside accommodations for our mothers and babies. We also have the Ronald McDonald House. We coordinate all services for discharge, including collaboration with DCPP, early intervention, outpatient, VNA. We also do telemedicine visits. We use the Vigo. It is a telemedicine robot, and I meet with the families after discharge where I can actually see the child, the parent, and the visiting nurse in the home, and they are free to ask questions, and we can continue to provide continuity of care. We also make appointments for our pediatrician and our neurodevelopmental pediatrician who continues to do the Bailey assessment at 3-month intervals. In terms of our developmental milestones, as I mentioned, we have a feeding specialist who works with those infants who are struggling. We have a physical therapist who addresses the gross motor needs. OT works with visual and auditory sensory inputs. We have recreation therapists and cuddlers who continue to work with the parents and families when the mothers can't be there at night. We have cuddlers who are there to hold and comfort these babies. We have child life specialists who teach mothers infant massage and continue with parenting classes. And I have a psychologist who performs the Bailey scales of assessment at time of discharge. One example that one may want to emulate is our model for inpatient therapy program for NAS. Our babies get anywhere from 6 to 12 sessions per week if needed for speech therapy, 5 to 6 for PT, 5 to 6 for OT. Infant massage may occur 1 to 2 times with the child life specialist and thereafter with the mother or caregiver who is trained. Therapeutic bath may be anywhere from 3 to 5 sessions per week. Our aquatic pool, 1 to 2 sessions. Our cuddlers, 1 to 3. And parent instruction occurs daily with nursing. I work with the mothers right at time of admission. I think one of the biggest challenges is to help mothers feel secure, that they are supported, that they are in good hands here. We are a non-judgmental, non-punitive hospital. We are here to help both the mother and the child. And our greatest hope is that for discharge to home, we have a trained mother who is taking care of herself, who is compliant with her own program, and works with DCPP and outside agencies for continued surveillance and monitoring of mom and the baby. We've had very good success. Our mothers love the program here, and they actually tell their friends about it. They said they feel that they can trust us, and they're more likely to stay compliant if they feel that they are respected. So we are very proud of our program. This is a picture of our aquatic therapy pool, which is just delightful for, there's nothing that a mother loves more than to get a little bathing suit for her baby and watch them in the water. This is a therapist who is administering a vital stim for a baby who is having problems feeding. The next picture just shows contingency learning. This one is infant massage. And this one is showing a range of modifications for adaptive positioning, for sensory awareness and interaction with the baby's environment. So we do a lot of what we believe are really good interventions for the babies and for the mothers. And we weren't sure if it was enough. We started to look at our outcome measures from the years 2009 to 13. We had 42 infants during that time period enrolled. We had Bailey testing on only 28 of them. And the reason for that is that, as I stated, most infants coming in with NAS are full term. And our program here, our infant therapy program, does Bailey assessment for outcomes on our preemies, our high-risk preemies, those that are on ventilators and TPN and extreme prematurity. So we never thought to look at full-term babies who were struggling with NAS. And as time went on, we recognized that we were recommending babies for outpatient feeding or gross motor or OT therapy. And we said, well, maybe we should start doing Baileys on these infants and see if we're finding anything. So that's why right now we only had, at that time, Baileys for 28 infants, because it was late into our outcome measures that we realized we wanted to start doing this. Our overall length of stay during this time period was, for these babies coming to us from NICUs, and that's the other thing I should mention, babies coming to us are often coming from NICUs, well baby nursery, or pediatric floors in the tri-state area. Very often we're getting babies coming to us because they are failing in their weaning process in acute care. These were babies who were started on either morphine or methadone. They were struggling with their detox. At about 10 to 11 days of life, they were doing better. They were getting ready to go home. And then there was a surge as they were coming off their medication. There was a surge in their Finnegan scores up to very high numbers, 14s and 15s. And it was felt at that time that these babies needed to come to us for ongoing treatment, as they were perhaps a different infant than the majority of babies with NAS who go home. We believe that is the case. We certainly see the hundreds of babies who are born with NAS. We get a small subset, and we believe these are infants who perhaps show a different demographic or a different physiology in terms of weaning than some of their counterparts. The discharges to home were 75% for the mothers, 25% for foster family. Medication-assisted treatment, 50% came into us on morphine, 50% on methadone. All 100% of these babies were weaned off their medications. Finnegan scores at time of discharge were less than 6. They all achieved age-appropriate weight gain, of which 70% still required high-calorie formula. All babies had a normal pneumogram. All caregivers successfully completed the independent trial and provision of care in the hospital, and all went home with involvement with visiting nurse and DCPP organizations. So when we started to realize that these full-term babies, who otherwise would have never been identified as having some issues, we're saying, wow, there's something to this. Should we actually start to look at the outcomes in development for our NAS patients, comparing them with non-exposed peers? So we wrote up a protocol, which was approved by Western IRB in May of 2013, and we did a retrospective chart review. Our hypothesis was that infants diagnosed with NAS demonstrate developmental delays compared to infants without NAS. We used the Bailey normative data which was historical data. We excluded premature infants or those who are considered medically fragile with any number of serious illnesses such as congenital heart disease, significant lung disease, chromosomal or congenital anomalies. So the Bailey, just to review for you, the Bailey 3, there's a Bailey 2 out, but the latest one is the Bailey 3. And it's designed for use for infants between the ages of 1 month to 42 months. It is a standardized tool that is derived from the assessment of 1,700 children with classifications derived from a normative bell-shaped curve. The Bailey subsets are in the areas of cognition, receptive and expressive language, gross and fine motor. The descriptive classifications include your scoring on the left. So scores on the Bailey of 69 and below were classified as extremely low outcomes, 70 to 79 borderline, and so forth. This is the composite curve for the infants that we tested versus the normative curve for Bailey. So the normal curve is in the yellow blocks, and you can see it takes a typical bell-shaped curve, starting with extremely low, going up to very superior. And we actually broke out our curves by function. So here we have the curve comparing the normal Bailey curve versus the scores on our patients in pink for motor. And you can see the distribution. Not too bad, but we certainly didn't have any children in the superior or very superior category. Here we have the cognitive curve. Again, yellow is the normal curve, and our patients are the dark blue lines. The language, yellow is normal, and the green curve is our patient population. So when we looked at this, our N was 28 out of 42 infants that we looked at. For cognitive scores, 7% scored in the borderline ranges, 70 to 79. 7% scored in the extremely low range for cognition, below 69. For total motor scores, 4% scored in the borderline range. For total language, 29% scored in the borderline range of these 28 patients, and 11% scored in the extremely low range. Our mean age of testing was 58 days. Some key points to remember when we talk about statistical analysis. The Bailey was established as a historical control group using normative population who were evaluated for the development of the Bailey 3. One group of infants totaled 1,700 infants aged 1 month to 42 months, which is the entire standard population of the Bailey 3. A second smaller control group of 300 infants were used, which we were able to pull out from the Bailey with permission from them, that were matched more closely in age to our group with a mean age of 60 days. And again, our population was 58 days. Our statistician used a standard sample of 2 sets of analyses. The 2-sample t-test comparing the mean composite scores for infants with NAS versus control, and the chi-square test comparing descriptive categories for NAS, infants, and controls. This was the t-test comparing the composite scores. The Bailey standard score was a mean of 100, the standard deviation of 15. And the chi-square, again, looking at the Bailey percentages versus our study group. The Bailey, again, the smaller group was 100 versus our study group of 28. This was the chi-square test looking at motor classification. So when we looked at the scores, what we found was that the mean language and cognitive scores were statistically lower, p less than 0.001 in our NAS group compared to a Bailey sample of 1,700 for the total Bailey standard, and a smaller group of age-matched controls of 300. We did not find significance noted when comparing male gender of which there were 57%. So we thought this was indeed very significant. We do note that this is a very small sample size. There needs to be continued data collection. We noted significant scores in the domains of language and cognition that were lower in the NAS group versus historical normative group. And we also noted also that we did have some delays in discharge due to caregiver identification. We did publish this paper that was in Clinical Pediatrics in 2014. Since then, our neurodevelopmental pediatricians have followed up on the original 28 infants after their discharge to home. They've so far been able to follow up on 16 of these children, of which we have data for 12. Of the 12 that they've been following up, both in their second assessment, which was anywhere from 3.6 to 8.3 months of age, or their third assessment, anywhere from 10 to 18 and a half months of age, they were still finding significant deficits in the area of cognition in the low average realm, 45%, 60% having issues in the total language deficits, 36% had lower scores as compared to their first assessment, so that was a trend we weren't expecting to see. 54% had fine motor deficits. One patient presented with emerging oppositional behavior at 18 months of age. One possibly with autistic spectrum needs to be followed more closely, and one with nystagmus. Because of the emergence of fine motor deficits in addition to our previously identified language and cognitive deficits, we were concerned that this might be an indication of more global delays rather than isolated deficits. And this is just a slide showing the comparison between our first study group at time of discharge and our follow-up from January 2014 to June 2015. So again, looking at our data, we feel that there is more work to be done. We seem to be obtaining infants from referral hospitals where the infant is failing their first phase of weaning and coming in along this biphasic curve after 2 weeks of life. So perhaps this represents a different type of patient than most of the infants that are either treated in acute care or discharged to home. We think we should start to stratify infants based on the severity of their admission Finnegan scales into two groups, those whose scores are less than 8 and those greater than 8, and compare that with their Bailey scores. We should evaluate the impact of treatment with morphine versus methadone on Bailey scores. We should continue to impose standardized weaning protocols based on evidence-based literature. And we should identify emerging patterns of difficult behavior or visual issues in long-term follow-up. So I think I kept it down to an hour. And I want to thank you for your patience and your attendance. And I open it up, I guess, Linda, to online chat and discussion.
Yeah, I'm going to facilitate the questions for you, Dr. Burke, but first of all, let me thank you. That was excellent presentation, and I'm certain that everybody listening really appreciated it and got a lot out of it. You covered a lot of the questions that were submitted originally. You covered a lot of this in your presentation. So I'm going to jump around a little bit, and I think and hit some of the highlights. First of all, when you talked about infants that present with neonatal abstinence, withdrawal syndrome, you presented a range from 55 to 94%. Am I correct with that? Can you talk a little bit about why such a range?
I think that's because of the degree of training of the staff who are scoring these infants. That is my best guess. This is in the literature, and it is a very varied, very high variance, that 55 to 94%. And I do believe it's in part the level of education and training of the staff who are working with these infants, and also in part related to the substances of abuse that may have been the infant may have been prenatally exposed to, so that there may be a range when they present. Very often, term infants are sent home at 3 days of life, 3 or 4 days of life, and they may not be presenting until 4 or 5 days, depending on the half-life of the drugs that they've been exposed to.
Okay, great, thank you. And that's certainly a good segue into a couple of other really critical questions. One of the things that folks asked repeatedly, and you touched on, was that sometimes symptoms don't present until 7 days, depending upon drug, depending upon severity. What does this mean in terms of early discharge from a hospital, and when the various hospitals start to look at their protocols, what does it mean in terms of how long they keep an infant for observation, and are there recommendations around that?
I think each hospital will be very specific, but I would give some general guidelines. If you have a history of very high-risk infant, I would at least keep for 3 days. Any symptomatology at all, I would extend it by a few days. And I think there needs to be very close follow-up with protective agencies, such as DCPP or visiting nurse, that will also be working with the family in the community for possible rebound or initiation of high Finnegan scores. I don't know that we can train parents competently in the administration of a Finnegan score in the home, and that's why I would draw upon the expertise of community agencies that they have very close follow-up with the families, as well as close discussion with the pediatricians in the community as well. We have heard of a few children who have gone home and have come back to our local acute care facility through the ER in severe withdrawal.
That's actually one of the questions. So if an infant begins to exhibit withdrawal and other symptoms after going home, what should the parents do?
They should call their pediatrician immediately, and I would advocate that they go to the emergency room with these children, because they are at high risk for high metabolic states, hypertension, and if the pediatrician can see the child in the office, fine. If it's on off hours, I would still call the pediatrician's office and then go to the emergency room.
Dr. Burke, one of the questions that came in, and you talked a lot about your non-pharmacological interventions and really stressed the importance of that. One of the questions that came in is, what's the evidence behind the rule of 24, and why do you manage these babies in a NICU as opposed to a general setting?
Again, I think that, again, I'm not an acute care hospital or specialty, but I think you need trained individuals to know how to administer the therapies. I'm a neonatologist, and I know what we do in the NICU, and I know what also goes on in the pediatric floors. And I'm concerned with the infants on the pediatric floors. They are loud, noisy. Sometimes they're put into a room that's relatively dark. And I don't know if they get the proper, the mission statements of most acute care hospitals are not to administer therapy. So I don't know if they have staff that can speak to the needs of these infants, be it sensory input, motor input, difficulties with feeding. I just do not know if a general ped floor can handle it. I do feel, at least in the NICUs, there was a little bit more specialty training, especially among nurses, on feeding difficult patients. You can certainly get consultations with PT, OT, and speech. I just do not know the frequency with which that would be carried out.
Great.
And of course, the physiologic parameters, once these babies start to withdraw, again, you want staff that are highly trained in the assessment with the Finnegan scale, as well as knowing when and how to initiate pharmacotherapy if necessary.
Great. I know that we are focusing primarily on babies that are prenatally exposed to opioids. There were lots of questions around exposure to alcohol and whether or not there are withdrawal symptoms in alcohol-exposed babies, and how do you manage that, and how do you identify babies that are fetal alcohol exposed?
As you know, fetal alcohol is an entity unto itself, and I dare say that's another webinar for another day. But we do know that most infants who have been exposed to alcohol in utero are severe IUGR, severe microcephaly, with a very definite physical stigmata, the flattened nasal bridge, the flattened philtrum. These children absolutely had a embryopathy related to fetal alcohol. It's pretty distinct. Their IUGR is way more severe even than what we see in the opioid-exposed babies. What we know from the literature is that the alcohol exacerbates withdrawal in opioid-exposed infants, but in and of itself, the greater issues are weight gain and growth, growth restriction and retardation, severe mental deficiencies, not necessarily developmental, but IQ, more related to IQ. But you're not going to know that in that newborn period.
You talked about the babies that come to you are often transferred from other hospitals, and obviously, having more difficulties with weaning and possibly have come back in. Talk a little bit about the impact of other factors during pregnancy aside from other, using opioids, whether that's other risk factors for high-risk pregnancies, and how that may affect these babies.
Are you speaking in terms of other substances of abuse or medical conditions?
Both. Polysubstance use, a late entry into prenatal care, whether or not, mom obviously poor nutrition, any of those other factors that may impact these babies. Tobacco use comes up a lot, and that's not considered an illegal substance.
Well, as far as, polysubstance abuse, again, it's going to take a very skilled obstetrician to work with this mother and get her to come forward and be honest and submit to regular screening and testing, because that's the only way, knowing at least what's in her mom's urine, how we can start to focus her management. Certainly good nutrition is critical for all pregnant moms, and very often we see that the moms with the worst nutrition have some of the smallest babies, both in terms of weight and head circumference. So again, that screening and that working very closely with the moms and making sure we can get them to go to centers that will work with them as high risk and to give them the appropriate medications they require. Maternal factors other than the poor nutrition would be, of course, monitoring these women for, they might be victims of abuse themselves. That should be determined, and a safe haven needs to be guaranteed to these mothers where they will not be going back into a home where there is violence, and certainly any other medical conditions, maternal hypertension, seizures. I have had several moms come in. As you know, pregnancy can augment the appearance of collagen vascular diseases, and I have a lot of mothers who started out with a relatively normal pregnancy, developed lupus or Raynaud's phenomenon, many with severe arthritis, and they get started on pain medications and get hooked onto the prescriptive pain medications. Those women need to be followed very closely, not only for their exposure to pain med, possibly the need for methadone, but also their own issues with their medical complications. I have one mother right now that is suffering from severe Raynaud's. So again, we want to be open to the suggestion that many of these moms have not only problems with substance abuse, but also their own medical complexities as well, which will always impact on the developing fetus.
Right, thank you. Well, one of the issues that comes up a lot for families that are involved in the child welfare system is this issue of breastfeeding and people not understanding the importance of breastfeeding. Can you talk a little bit about decisions about breastfeeding, why it's okay, when it might be contraindicated?
Yes, again, I am not the law of the land, and so I really read up very closely on all the issues by American Academy of OBGYN, American Academy of Pediatrics Health Organization, and they strongly recommend that moms be allowed to breastfeed, and I do support that. I believe the only contraindication is in situations of HIV positivity in the mother and where Suboxone is used. Many providers of treatment for moms during pregnancy are not schooled enough in what should be given to pregnant moms. most of them should be transitioned off of the Suboxone because of the component of naloxone in it and transitioned to Subutex. And I believe there are many providers out there that still need more education in this arena. Other than Suboxone, it is recommended that moms on methadone or buprenorphine be allowed to breastfeed. It helps with bonding, certainly helps with immune protection for the infants, as well as nourishment. And the studies have shown that the amounts of methadone that cross into the breast milk are so very, very small that you can hardly measure them. So it is strongly recommended that moms be allowed to continue to breastfeed where possible. There are some other indications. If moms have screens where there are illicit drugs, then they should not be allowed. That's why it's very important that as pediatricians we work closely with DCPP and other agencies that can do some of the detective work for us to help us make these medical decisions.
Right. You mentioned that for the majority of your infants, they're going home with mothers. In the event that they may go home to another out-of-home care placement, what do you recommend for those caregivers in terms of interventions, things that they can do to mediate some of these effects?
Right. Once there's been a caregiver identified by DCPP or the courts, we take them through the same training and education process that we would through a biological mother. So we put them through all the training in terms of calming strategies, feeding strategies, how to make the medication. If they require extra medications for reflux, we bring them through all of that. And we make sure that they are followed up the same way with medical subspecialty follow-up as well as with DCPP and visiting nurse.
And again, Dr. Burke, I realize I'm jumping around a lot with this. I'm trying to cover as many of these questions as possible, but there were lots of questions around screening and testing babies at birth. And I realize a lot of those infants are transferred to you and not necessarily born in your hospital, but can you talk a little bit about that testing process and what you would recommend?
Yes. I think it's a process that's filled with frustrations. When I talk to my colleagues in acute care centers, most of them have access to urine toxicology. In fact, I think all hospitals probably have the ability to do urine screens, urine toxicology on the newborns. Again, some of those yield positive results, some of them negative results, even where you have a positive history in the mothers. And in those cases, I would opt to rely on the history and monitor those children very closely for signs of withdrawal. We also know that there are a few hospitals in New Jersey that are doing research on the hair analysis and umbilical cords. So I think those are probably expensive tests to do unless you are in a research facility. But over time, as the research comes out on that and it indicates whether or not we should be using hair or umbilical cord analysis, once that statement is made, I would hope that the expense for doing these testing is not cost prohibitive and more acute care facilities will be able to follow up, because clearly there are much more positive results that will be yielded with both hair and umbilical cords. So again, it can be frustrating because you have a mother who may be in treatment with methadone throughout the pregnancy or illicit drugs. She tells you that, and the baby's urine screen is negative. I would not let that stop me. I would go ahead, monitor this child very closely for withdrawal symptomatology.
You know, it's interesting. You talked a lot about the importance of understanding mom's prenatal history and certainly also understanding babies. But the difference between getting a positive tox for the purpose of identifying a baby that's subject to abuse and neglect versus getting that information, prenatal history, and the baby's toxicology to really determine the best interest of the mom and the baby. What are the right interventions for that baby? Why is that so important? This speaks a lot to the work that you're doing around the Bailey as well too, but can you talk about why it's important to really understand, not from an abuse and neglect perspective, but really to understand the needs of that baby and the mom.
Right. So again, you want to have an open relationship with the mother because, first of all, you want to have a successful and safe pregnancy. You want her to be able to come to term with the baby, to carry to term, to have a healthy infant as much as possible, good nutrition and good support of the mother. Because our preliminary studies are starting to show us that some of these babies who are otherwise full term are presenting with some possible delays in their developmental milestones or in the areas of motor and language, it would be very important to continue with the screening of these infants. Most of these babies who don't come to us and perhaps are treated in acute care and go home, as full-term babies, they're not being screened, and I am worried that some of those infants may not be getting the early services they require. I don't know that pediatricians, busy pediatric office, is able to screen these infants. So some of this might be helpful from our perspective to work with community pediatricians and say, you know, a baby that did come through us, we are concerned is showing some delays. We are going to refer to early intervention and continued surveillance of that child. Because I really believe if we can make an impact in the early days for these children and give them the therapies they require, they may not require full services by the time they get to school age.
Great. Thank you very much. You know, one of the questions that's come up during the course of your presentation, and I think it's a natural question to ask, is you have a marvelous array of services. You have a marvelous program. You have a wide range, a wide array of staff working with you. How do you fund it? How is it funded?
We work with insurance companies. We're a nonprofit. We do work with the insurance companies. In fact, many of them are asking us for continued research in these areas and to collaborate with other hospitals because they are trying to understand themselves what the needs are of the infants. And we do work very closely with the insurance companies. And whatever. Oh, and I'm sorry, my colleague is here, and with Medicaid as well. So with HMO Medicaid and with Medicaid services. And,
was that
again,
was that David?
I don't know. That's David, yes.
Okay. Dr. Burke, I have a couple of more minutes, and I think you started off, we started off by talking about there's a wide variation in hospital protocols, clinical pathways for both identifying and treating infants with neonatal abstinence, certainly infants that are prenatally exposed to substances. If you were to recommend, for hospitals that may not have the ability to provide the wide range of services that you do, if you were to recommend certain elements that you think should be there in all clinical pathways for these babies, what would be the things that you think are the most essential?
Right. Yes. Again, we do have the luxury of being able to provide a tremendous array of services, but if I were to venture into a model for hospitals, whether they be acute care or any other type of hospital, you want to make sure that the information you have is correct and available as possible in terms of maternal screens and infant screen and history. With a positive history, I would monitor that baby very closely in the nursery. If that child is showing positive signs of withdrawal, it might do you well to train some of your staff on the administration of the Finnegan so that if a child requires pharmacotherapy, we feel that it is a reliable score. I would always, for the child that is withdrawing, I would always start with the non-pharmacologic interventions. Perhaps you can train cuddlers or volunteers to help in this. I would propose that at least to the hospital administration. I don't know if you'd have enough staff, so I would work with cuddlers and volunteers. Very often working in nurseries is where many volunteers like to be of service. If you need to treat, either the NICU is trained in the protocols for treatment and pharmacotherapy, or send them to a center that is competent and trained, because detox is a very risky business, and you want to make sure you take that child through a slow and steady course without risking a rebound. You would certainly want to also engage DCPP and community services to help you with the discharge planning. and where possible, try to either test these children or make referral for EIP in the community, where they will test the children to see if they need ongoing therapies or referral for EIP. Also, I feel very strongly that no baby who is going through withdrawal should be discharged home while he is still actively withdrawing. I do not believe there are enough pediatricians who have the time to monitor these babies, and I don't even know if there's enough community services. We have gotten back a few babies who went home who were still on medication. Those babies had a very negative outcome. One had seizures, one went into cardiac arrest. So I think that detox for a baby, just like an adult, needs to be handled seriously and by experts in the field.
Great, thank you very much. We know that we have all 6 of these states. We have a few other folks that are on the call with us today, but most of the people who are on the call today are partners in this 6-state initiative trying to address this, just as you are in New Jersey. Is there anything that you would want to say to these 6 sites about your recommendations for moving forward, or what you think is critically important? This is your chance to provide us all with some recommendations.
I would love to see us continue to work and collaborate, because I think putting the best minds together from whatever states are interested in helping to further the medical care for the mothers, the screening for the mothers, services for the mothers, and then ongoing services for the initiation of care for infants, regardless of the setting. But I think we have to put our heads together and think about cost factors, what that would look like in terms of financial picture and structure. I do believe these infants require ongoing care and supervision in a specially trained center. Of course, I am an advocate for ongoing acute rehabilitation for those infants that do require it, and to organize community services as best as possible so that these children don't get lost.
Great. I appreciate your time. I know you put a significant amount of time and energy and thought into this presentation, and we all greatly appreciate it. And we look forward to continuing to talk with you and work with you in the future. For all of the rest of you on the call, we're going to be looking at questions and a process for providing feedback to you on some of the questions that were not addressed, certainly those that pertain to mother's treatment. And there were a lot of interesting questions around cross-systems collaboration, and Dr. Burke just touched on the importance of that as well. So we will be getting back to you on that. We expect that our next month will be more of a dialogue between the sites as opposed to expert presentation, and then we'll probably follow that up with another expert presentation in November. So we look forward to, we had a total of 95 people join on today, and we know, Dr. Burke, that in some cases there were multiple people in an office. So good turnout for today's webinar, and we appreciate all of you being on.
Thank you, Linda, and your colleagues, and to the participants. I look forward to ongoing dialogue to tackle what is a very big healthcare issue in this country.
Great. Thank you so much for your time.